it has a comparable fracture prevention at the vertebral site and have definitely more fracture prevention at the hip side. And you have also accepted that there is a trend towards reduction in the hip fracture, but I think we cannot give this drug for more than 24 hours. That we cannot say that whether it will improve that one. So we have a drug which have a proven efficacy both at vertebral fracture and both at hip fracture. So that is the one. And second thing, uh, as far as the side effect profile of concern, I don't know how many patients with osteonecrosis of jaw or atypical fracture you have seen, and both of them will be the physician fault rather than the patient fault. So the patient may, I have seen few patients who are on cancer treatment receiving teriparatide once in 3 months or 6 months, and they come with an atypical fracture, but not a patient who are on a regular follow-up where they can come back to that one. And in terms of the cost, I think you should accept that cost and ease of treatment. You should accept that bisphosphonates are better in terms of mass treatment. That is my one of the important thing. And I will agree with that. Any patient who have severe osteoporosis, definitely I will feel that to build the bone, then I think teriparatide is the best drug, particularly in terms of vertebral pain. I have seen several patients who are after starting teriparatide who have a low back pain, who have compression. They have a significant improvement in the pain score, and also they tend to feel better rather than starting bisphosphonate. So I think both they have indications. And as far as a drug of choice, what I feel in a common variety of osteoporosis, I feel that bisphosphonate is the drug of choice. Thank you.
Dr. Ravi?
Um, I think I will put my bet on one factor. Of course, cost is an issue. The problem is getting solved with generics nowadays. And I agree that osteonecrosis jaw and osteonecrosis jaw especially is quite rare. Atypical fractures we will come to see after 5 to 7 years of use. So if we give a drug holiday for bisphosphonate, we may avoid that complication. There are ways to work around that. The main issue is at 50 or 60 years of age, the bone mass is already suboptimal. With bisphosphonate as the initial agent, we will manage to only at the most just preserve 80% or 90% of that already low bone mass. Now I think if you are not talking about a very long-term agent, but simply the first agent to use, probably teriparatide scores better in that aspect. Because a very rare side effect of osteosarcoma in rats, the 2 years duration limit has been imposed. In humans itself, it has been very rare. Only 3 cases in 250,000 patients have been found osteosarcoma. That may be just a normal incidence. So in a new case of osteoporosis, if cost permits, teriparatide will be the better agent among the two to increase the bone mass, which can be preserved after 2 months with the use of bisphosphonate. Thank you.
Thank you to both the speakers. Now, I work in an orthopedic hospital, which is also a general hospital, and fairly good experience over the last 12 years using these drugs. Now, one of the orthopedicians told me something very unique. He said, if you don't have any money in your bank, no purpose in stealing it. First, you have to put money in the bank, have a healthy bank account, and then make sure that you don't lose it. So, in other words, bisphosphonates in early cases, if there is a sufficient bank account, are the drugs of choice. But if the bone mineral density is very low, the T-score is very low, at -3, -3.5, I think anabolics should be preferred first and given for a finite period of time. Theoretically, we have to give 2 years, but due to the personal cost factors, most patients are not willing to pay for 2 years. So as long as they are willing to pay for it, I ask them to take the anabolics. Following which, Of course, the moment we stop it, the bone is likely to go back to its original course. So to sort of maintain the thing, next we continue with bisphosphonates. Of course, not more than 3 to 5 years because of problems of osteonecrosis jaw and also the atypical fractures, which I have seen myself. Of course, now instead of bisphosphonates, we have the option of denosumab, which is now freely available. Even generics have come for denosumab. What was 21,000 rupees is now available for 13,000 rupees. And this is much more convenient in the sense once in 6 months injection only. So as an endocrinologist, you have more options than what you had 10, 15 years back. A proper selection of cases and choosing of drugs would be the ideal case. Before I think both the speakers did an amazing job, and we should congratulate them for it. There are two, three questions in the chat box, which I think I'll answer. First question was, can we use combined both the drugs? Please do not do so. Combined effect is not, they're usually a negative effect. You have to use them serially. The teriparatide followed by bisphosphonate. The second question was, can you use this teriparatide in a normal postmenopausal woman? The answer is a big no. Unless necessary, you don't have to use teriparatide. Just give calcium, vitamin D, it is more than sufficient. And then the third question is, after 5 years of bisphosphonates, should we follow up with calcium and vitamin D supplements, or is another option available in severe osteoporosis? Yes, denosumab is the next option available in osteoporosis. Guided physiotherapy will certainly help atypical fractures. So these are the various questions available. Any other comments? If not, I thank once again both the speakers for a lovely session. And now it's back to the organizers.
Thank you, sir. Thank you, Ravi Kiran. Thank you.
Thank you, Dr. Prabhu.
Yeah, fine.
Thank you very much, sir. Thank you.
I thank our speakers for the informative sessions. Now we move forward to our next panel discussion on electrolyte disorders in endocrinology. I would like to welcome Dr. M.V. Ramamohan for chairing this session. Sir is DM Endocrinology from Andhra Medical College, Visakhapatnam. He is consultant endocrinologist and diabetologist in Diabetes and Endocrinology Clinic, Nellore, Apollo Specialty Hospitals, Nellore, and Star Hospitals, Sriharikota, Nellore. Welcome to you, sir. Kindly take over.
Yeah, thank you so much, madam. It's indeed a pleasure to be with all eminent endocrinologists. Today, our topic is electrolyte disturbances in endocrinology. For the panel discussion, I would like to introduce three eminent endocrinologists. First one is Dr. Kumar Tulsidas, sir. Welcome, sir. Sir is a MD, MRCP UK, MRCP endocrinology diabetologist, present at consultant endocrinologist and diabetologist at Kamakshi Memorial Hospital, Chennai, and SRMC, Porur, Chennai. And he completed MBBS from Tanjavur and MD from Kilpauk Medical College. He is an assistant professor of medicine at SRMC from 1990 to 2002, completed endocrinology training at UK and member Society of Endocrinology UK, and he has many publications and case reports. And I welcome Kumar, sir. It's indeed a pleasure to have you on this Trendo meeting, sir. Thank you so much. Next, I welcome Dr. Aruna Chilia. Madam is a present is MD Internal Medicine, Diabetes, Metabolism, Endocrinology, American Board Endo. Affiliates consultant Alpha Hospital and Research Center, Madurai. And achievements, she has a teaching, attending mentor for medical students, residents, nursing practitioner, physician assistants, and internal residency program, York Hospital, Pennsylvania. And she had a clinical effectiveness team in participant outpatient diabetes management at Wellspan Health. Then she worked in head quality assessment improvement projects, diabetes, metabolism, health, and led a Wellspan endocrinology to recognized as a first specialty patient-centered medical home in central Pennsylvania, designed CPOE, computerized provider order entry system for electronic and medical records, inpatient, outpatient, diabetes, and endocrinology, and standardized workflow process in WellSpan endocrinology. And she is a faculty for diabetes clinics, education programs, primary care physicians, and conducted many diabetes self-management education programs, medical nutrition therapies. I welcome you, madam, to this Trendo panel discussion. And then I welcome Dr. R.M. Manikandan, MRCP UK, MRCP Diabetes and Endocrinology, consultant endocrinologist, Apollo Hospitals, Madurai, and EC member of ESTN. Thank you so much, all the three eminent panelists here. And it's indeed a pleasure to have all of you on this platform. Thank you so much, sir. And today, the flow of this 1 hour will be we'll be discussing about common electrolyte disturbances which we see in day-to-day endocrine practice, and the importance of electrolyte imbalances as an internal medicine. We know that electrolyte imbalances cannot, or the disturbances of dyselectrolytemia cannot be taken in a light process, and these are the things which cause morbidity and mortality in all our patients. So that strict vigilance about the electrolyte disorders is indeed very first priority to all the cases which we see in our practice in endocrinology, and we'll be highlighting this process not in a didactic way. We'll be having 3 to 4 case discussions, so that we'll be discussing about different parameters, different differential diagnosis, treatment protocols, and what are the things which you should remember when you see a patient, different patients of endocrinology, having in mind that electrolyte disorders in the background, so that this flow will help our patients or help our faculty to know about electrolyte disturbances in the endocrinology. So thank you so much, Kumar sir, Manikandan, and Aruna madam. Thank you. And I'll be sharing screen. Sir, are you able to see this, sir?
Yeah. Yeah.
Yes, sir, fine. So, so coming to the case one, I'll be presenting the case and then we will go for discussion. A 77-year-old male admitted with mild confusion, forgetfulness, history of fall once in last 2 to 3 months, with no history of fever or seizures or fluid loss, had a history of CVA 2 years ago, and systemic hypertension, pulmonary TB completed 6 months before, on clopidogrel, statin, and cilindipine, and there is no history of diuretic use. This was a presentation. On clinical examination, patient was conscious, slightly disoriented, and afebrile. Pulse is 70 per minute, BP is 132/80, and there is no peripheral edema or ascites, and tongue was moist. No postural drop of blood pressure was there, and there were no signs of meningism or focal neurology. So from the history, sir, Tulsi sir, can we go
Yeah.
for any differential diagnosis? Can you
Yeah.
please?
Good morning, everybody. Thank you, Dr. Rahman, sir, for the kind introduction. This patient, given the history, is an elderly patient, given the history of CVA in the past and pulmonary tuberculosis. A few things come to the mind, and prominent among them is forgetfulness and gait disturbance, probably had a fall. So recurrent CVA is an option, and the patient is on clopidogrel, and any head injury could have caused a chronic SDH, which is also a possibility. So any cerebrovascular events. Other than that, I would also like to consider metabolic factors like sodium or glucose and things like that. Vascular dementia is also a possibility because of recurrent CVA that could have happened, with quite a few things in mind. On examination, more importantly, this patient was slightly disoriented, but the patient had a normal pulse, a normal blood pressure, tongue was moist, and no skin turgor, and skin turgor unreliable in elderly. But he did not have any edema or any ascites, any fluid overload status. Tongue was moist, no postural drop. All these features indicate that the patient is euvolemic. This is an important clinical feature we should pick up in this case. Also,
we had clinically ruled out a meningism. The neck was reasonably supple and there was no focal neurology. So these things in mind, we proceeded with the investigations.
Yeah. Uh, so any inputs, Dr. Aruna madam, from your side about this case? Any observations from the history?
Yeah, how about, I think that patient is not being hypertensive is very important. Here we have ruled out adrenal insufficiency.
Yes, madam. Sir, Manikandan sir, from the history.
I think Dr. Kumasa has covered most of the things what we would like to know. So I think I will proceed with the investigations.
Yeah, thank you. So on investigations, CBC was normal. Sodium was 124 with potassium of 3.8, chloride 102 and bicarb of 26. Urea was 1.18 and creatinine was 0.9 with blood sugar of 102. Serum osmolality was 287 with urine osmolality of 302 with urine spot sodium of 68 and FT4 and DSH were under normal limits. Lipid profile was normal. Cortisol at 8 am was 14.1. Uric acid is 2.8. MRA showed old CV changes. CT chest, there was a healed TB scar. So back to Tulsi sir. Can you go ahead with the investigations?
Yeah. Sure, certainly, thank you. So the sodium here prominently is 124. So there is hyponatremia here, which is not mentioned here. Was 6 months ago when the patient had tuberculosis treatment. They had an old record of showing 129 sodium, which was unfortunately not investigated further. And there have been low sodium for a while, which is an important feature we should pick up. And renal functions are normal. And the sugar was normal. That is important because very frequently the hyperglycemia, when it is very high blood sugars, can cause pseudo hyponatremia. In that case, when the sugar normalizes, the sodium also goes back to normal. So one should not rush into make 3% saline infusions and stuff like that. So that is quite important. And the osmolality, urine and sodium. So serum osmolality, we know that it is a euvolemic hyponatremia now from the clinical examination. And the osmolality to confirm it is a SIADH, that should be the foremost thing in our mind because the most common euvolemic hyponatremia is SIADH, and we should see whether it fits into the diagnosis. For SIADH, the serum osmolality should be below 275, which is 275, 295 normal. The urine osmolality should be at least more than 100, not necessarily more than serum osmolality. And the urine spot sodium, generally it is below 40 normally. It should be above 40 at least. The urine sodium excretion is increased. One is because the water excretion is not adequate that in the urine, that brings up the sodium, as well as the volume expansion intravascularly because of water retention also promotes this natriuresis a little bit. Thereby the urine spot sodium is elevated, but it is not a hard and fast rule. Suppose we put them on fluid restriction, salt restriction, fluid restriction, then the sodium may change. So to begin with, if it is more than 40, it goes in hand with the SADH diagnosis. There are a few other things worth mentioning. The thyroid function tests have been checked, which is quite important because in thyroid, if TSH is elevated, that in turn stimulates the ADH release, and there is increased ADH levels leading to water retention, and so dilution happens and hyponatremia happens. So we have to make sure the thyroid functions are normal before confirming it is SADH. The next one is lipid profile. Why is it done in this patient? Again, the pseudo hyponatremia. If the triglycerides especially are very high, exorbitantly high, which we never know, and these patients can have pseudo, because in all the most of the labs do sodium estimation by a method called indirect ISC. This will look at the water content. Generally, it will look at the 93% of the water content, 7% of the protein or other lipid-like substances content, and it will assess sodium only in that particular water content. So, if the protein or the lipids are increased, then it will read as the water content as less, and so the sodium content it will read as less. But actually, the total sodium content will be normal totally. So direct ISE methods can assess the electrolytes more appropriately, but make sure lipids are normal. Again, most important is hypocortisolemia, as Dr. Arunam had mentioned. So when there is a mineralocorticoid insufficiency, the sodium retention in the renal tubule reabsorption is defective, and the potassium excretion happens. So when this happens, then the sodium can be falsely low because of adrenal insufficiency and not exactly due to SAADH. So that we have to be careful in ruling out before confirming it is purely SAADH. Serum uric acid, this is a corroboratory finding because the fractional excretion of uric acid is elevated due to volume expansion and due to ADH action as well in SAADH patients, and thereby more uric acid is elevated. So anything less than 4, we can take it as a corroborative finding for SAADH. This patient had MRI which showed some scarring features, as well as chest CT showed some scarring features as well. Because whenever we find an SAADH in an elderly patient, we have to think about the causes, whether it is malignancy related, which is very common, or it is any pulmonary lesions, healed or active lesions, or any CNS tumors or other causes. So we have to do these investigations to look into. There are lots of causes to say, but these investigations are helpful to pinpoint the diagnosis.
Thank you, Kumar sir, for the detailed explanation. And Madam, are you having any inputs from these investigations?
No, pretty much he covered it.
Yeah.
Thank you.
Mani sir.
It shows definitely, as Dr. Kumar sir extensively explained, that there's lots of features suggestive it's SAADH. One thing, one caveat which I would like to add is we need to make sure that they're not taken diuretics. I know that sir has shown the medications what they're taking, because diuretics can also fool us because they can increase the spot urine sodium. So I think that's a detailed history. That's one other thing what I'd like to add on. But otherwise, he's explained everything in detail.
Yeah.
So we can I mean going into the mechanisms, if you would like to, the CNS tumors can produce, because they have inputs into the hypothalamus. One mostly by directly stimulating the hypothalamus to secrete more ADH, and that is the mechanism how the cerebral lesions cause the SAADH. As far as pulmonary lesions are concerned, though, that's why we did the CT. They say that is one of the very common causes for especially elderly patient. Very small cell carcinoma in particular can be missed, and that could be causing this problem. And because of the past history, we may be thinking about all other things. So there are many malignant lesions in the lung as well as elsewhere in the body can do this. Some of them secrete ADH themselves ectopically. Some of them just to make the ADH increase from the pituitary gland. Either way they act. Head and neck cancers are second most common cancers, but other cancers also can do, like intestinal cancers, pancreatic cancers, uterine cancers. Pretty much any cancers can lead to this SAADH syndrome. Lung lesions, pneumonia, TB, in this case TB, even healed TB many times can lead to SAADH. Even acute pneumonias, the bacterial, viral, TB pneumonias, or somebody put on a ventilator or mechanical ventilation, they all can cause SAADH. Drugs, as mentioned, drugs can cause SAADH. Some of them stimulate AVP release directly, like antipsychotics kind of medications. Some of them increase the potency of the ADH hormone acting on the kidney, or directly stimulate. Like very commonly we see this SSRIs, the citalopram, venlafaxine kind of medications. People or AC inhibitors themselves, ARBs. Very commonly nowadays the omeprazole, lansoprazole combinations are very commonly. Once you stop them, not only this, even in prolactin, many hyperprolactins, they are appearing to be more and more implicated in them. Those are the ones, as well as other anti-epileptic medicines like carbamazepine. Those kind of medications can also cause SADH. And having said all this, in elderly population, very frequently in my practice, I've seen a lot of idiopathic SADH. They say in elderly people, up to 60% can be completely idiopathic. In this patient, maybe the healed TB causing in the chest or the old CVA scar, whichever may be triggering the ADH release and causing SADH would be my bet in this patient.
Yes, absolutely, sir. So then we go to the treatment part. So Tulsi sir, can you explain?
Certainly, sir. Certainly. So this patient, as I mentioned, appears to be slightly chronic. No sudden clinical symptoms. Chronic hyponatremia would be more appropriate in this patient to say. So to begin with, we started, and he did not have any cerebral edema or anything going on. So put him on fluid restriction to begin with. Within a couple of days, it only improved up to 126. And clinically, he continued to be euvolemic. We were assessing every day. And then went for this ADH receptor blockers. The tolvaptan, they act on the ADH receptors in the renally as well, and block the action of this ADH, thereby promoting free water excretion. It is generally started 15 milligrams daily, but after starting, we have to be very careful in monitoring the sodium, which doesn't happen frequently unless we tell the other doctors, because they even when this has become very common for many junior doctors to somebody seeing low sodium put on tolvaptan because it's freely available, so they have to know the implications. So initially he was monitored twice daily, and we knew that the sodium was only gradually coming up. So when increased, and then slowly it was coming up to 128, 130. In a week's time, it was 138. And even when it crossed 130, we had actually stopped this, reduced this tolvaptan even to half to slow down the rise, and he was stable with that dosage. And then we allowed him to drink to thirst. There is no need in chronic hyponatremia due to SADH to really restrict when the initial sodium has improved. And so he was drinking to thirst, but he was taking the tolvaptan, and that was keeping his sodium good. Some people, as Dr. Manikandan has mentioned, if the diuretic is used on such patients without knowing, it can produce an acute hyponatremia because they already have a background hyponatremia. And they come with somebody with 103, 109, where we don't have an option. Of course, we have to correct their volume, but we also have to think about 3% saline infusion, because delaying treatment of acute hyponatremias can be harmful to life, even because of life-threatening brain edema. So it is important to correct. At the same time, unless we know the exact timeline that it has come down quickly in last 12 hours or so, the bolus of 100 mils, 3% saline can be, we can try to come down on that and try to improve the normal 3% saline infusion in an ICU setting. But the only thing is every 2 to 4 hours, first 1 or 2 days, we have to monitor when the sodium infusion is on, make sure it doesn't come up too quickly. So the take-home message in this case is, commonest cause, you will have somebody with a low sodium, you examine very, very carefully clinically. That is the most important thing in this, what I want to drive home, because completely if they're dehydrated, the treatment is different, and euvolemic, the approach is different. So as I told, the criteria for diagnosis I've mentioned, make sure you rule out other causes, adrenal insufficiency, hypothyroidism, or renal or cerebral salt waste in background conditions. Acute hyponatremia, it's a different ball game. Ensure correction and make sure the correction doesn't go beyond 12 millimoles per day to prevent the pontine diagnosis. Look for underlying causes, but remember, if you don't find anything, don't get disappointed. You may well be on track. It could be very well idiopathic, especially in elderly population.
Yeah, so, fantastic, Kumar sir.
Thank you.
Can I have a minute inputs from Mani sir and Aruna madam about hyponatremia, about other endocrines? Anything?
Well, I think Dr. Kumasa has done a very comprehensive review with the results and what his patients went through. Couple of points I would like to add is emphasizing what Dr. Kumasa has already said. One is 12-aptan is not the cure for all hypernatremia. That's one thing I think the junior doctors need to realize, because in clinical practice, because it's easily available, as he said, everyone who walks in with the hypernatremia, whether it's 101 or 125, gets put on 12-aptan. Especially for acute hypernatremia, I think we should avoid tolvaptan, especially when sodium is very low, because we don't have a control over the rise in sodium. And pontine myelinolysis is a very important thing we need to avoid. So we need to show caution, and I think tolvaptan needs to be used very judiciously, and it's not a Sarvalo Nivarani for hypernatremia. I think that's what all the other specialists and junior doctors need to realize. And second thing is, completely agree with Dr. Kumasa that we need to rule out other causes of hypernatremia before we label someone as SADH. That gets missed quite a lot of time, and everything is assumed as hypernatremia, because even dehydrated patients get put on 3% saline and tolvaptan, which is going to exacerbate their hyponatremia. Otherwise, fantastic presentation. Thanks so much, sir.
Thank you.
Dr. Kumar has done an amazing justice. Thank you, Dr. Kumar. And of course, Dr. Manigandan has really summarized it beautifully. Nothing more for me to add other than tolvaptan. When I was in US, it was the drug of choice for the nephrologists there. Unfortunately, we endocrinologists always had to say no to it. So it was like a go-to drug, and we had to come in and say no. So the thing that I really primarily had problems with, we used to have tons of course, I'm not sure about psychiatric diseases here in US, it's pretty high. So SSRIs is given out like candies. So we do see a lot of hyponatremia, which doesn't need to be treated. They don't need to be treated. They need to be just monitored if they drop further by like adding a diuretic or not. And also with the patients who are on antipsychotics who need to drink a lot of water. And that's, again, is the biggest issue I've found very difficult to manage. So it was very intensive, I would say, education, especially family education that we had to do regarding the fluid intake, not just water intake, the total fluid intake. And really that really helped. And in older patients, I saw reset osmosis. Most of the time, the sodium levels reset. So you don't necessarily need to treat them, as long as the patient was aware that this is their reset new level of sodium, and wherever they go, they notify the physician, so their baseline is noted. Thank you very much.
Yeah, thank you, madam. Thank you. See,
Ram,
yeah, we'll go to next case.
Before we go, there are a couple of questions about hypernatremia from the delegates. Can we answer that now itself, or shall we have it at the end?
At the end, sir, we can go at the end. So that, yeah. So then comes to Addison's and hyperkalemia. A 38-year-old lady with hypothyroidism on thyroxine 75 micrograms with weight of 88 kgs and BMI of 23. Presented to a gastro specialist hospital in Coimbatore with 2 months history of nausea and vomiting with 10 kgs of weight loss. Had consulted multiple doctors and various hospitals with same complaints, noted to have normal thyroid functions and other investigations including CT scans. In Coimbatore, on 24th November, she was noted to have sodium of 119 and potassium of 5.7 with had a sodium of 128 to 135 her last 2 months with various labs and referred to an endocrinologist. So next day morning, cortisol was less than 0.4 microgram per DL with normal TFTs and gonadotropins. Advised admissions, but decided to come to Madurai near family hometown. On examination, well, dehydrated, BP was low 90/60 with pulse rate of 110. Hyperpigmented hands, face, buccal mucosa was dark and GCS was 15/15. 9 p.m. cortisol was 0.5, sodium 103 and potassium was 5.6. And so she was given IV hydrocortisone 100 mg stat and 50 milligrams of QAD along with 0.9% saline 100 ml per hour. Sodium 111 and 119 next day, and IV fluids were stopped, switched to oral hydrocortisone, was given 5% dextrose, and avoid rapid rise of sodium. And then sodium was 124 and 124 and 28. It was 127 on 29th and 29 and 30th. And ACTH reports were pending. So Dr. Mani sir, your inputs from this.
So thank you so much, sir. This case is someone who presented with Addisonian crisis. So she has struggled with nausea and vomiting for quite some time. The family were really worried. They couldn't find an answer. So they went to different hospitals. And I think the penny dropped when she presented to the gastro hospital. When they did all the blood tests, they found that the sodium was low. It was around 119 with a slightly elevated potassium of about 5.8. So that's when they thought that this could be an endocrine reason rather than other reasons. So they were referred to Dr. Suresh Damodran in Coimbatore. And fortunately, before he saw the patient, he had a very low cortisol. So this was the proof what we needed, and the patient was advised urgent admission for further treatment. But because of family issues, they came to us, and by the time she came to us, she was really dehydrated and she was tachycardic. So the clues for Addisonian crisis in her was she was in an early shock state because she was tachycardic, she was in hypertension with hyponatremia and hyperkalemia with increased pigmentation. So the treatment ideally is to give fluids and also give steroids. So we prefer to give hydrocortisone because it's got both glucocorticoid and mineralocorticoid activity. So it will get her out of the adrenal crisis and also get her electrolyte imbalance better. But as we discussed earlier, we do not want the sodium to go up very quickly. But most of the time in Addisonian crisis, when they have severe hyponatremia, it rises rapidly as soon as the cause for hyponatremia is corrected. So in SADH, usually when we correct the cause, it comes up slowly. But here, because there are two driving forces, one is the mineralocorticoid deficiency and also inappropriate ADH from glucocorticoid deficiency, both cause severe hyponatremia. And when we correct it, it goes up. So we were in a dilemma the very next day because it was 119 the day before when she came to us, presented to us. She came quite late in the night. And when we repeated, it has gone down to 103. So when we repeated it, because one of the things to do with severe hyponatremia is to repeat the sample because we don't want to be treating a lab error. So we repeated it, and at midnight we had the report of 103. She had already had the first dose of hydrocortisone by the time. So we took the sample and gave the IV hydrocortisone within 20-30 minutes after she reached the hospital. And by next day morning at 6 o'clock, it has jumped already by 211, which is about 8 milliequivalent rise. And by evening, it was 119. So that's about 16 milliequivalents, which is much higher than what we will recommend. We would recommend it to be rising at the rate of 8 to 12 milliequivalents every 24 hours to avoid pontine myelinolysis, which, as Dr. Kumar said earlier. So we did an unconventional thing by stopping the IV fluids. And within 24 hours, even she was stable. She was much better than the very next day. So she started eating for the first time after nearly a month or 6 weeks. And she was very happy the next day. So we switched over to oral hydrocortisone because we could reduce the dose and also assuming that it might reduce the rapid sodium rise. And the fluids were switched to 5% dextrose. Ideally, in Addisonian crisis, we should not be giving hypertonic solutions like dextrose. But to avoid the rapid rise, we gave this. And in spite of that, the very next day morning, it was 124. So this is a sodium rise of about 21 in 36 hours time. Luckily, she was not having any symptoms of pontine myelinolysis. So we continued 5% dextrose and it started stabilizing. The patient was completely well throughout this and she got discharged on 30th when she was stable. We're still waiting for ACTH report. So I think the main thing with Addisonian crisis is this is presented to me with all the results in front of us. So it was very easy to manage, but most of the time adrenal crisis doesn't present like this. So if you're worried about adrenal crisis, ideally the treatment should be started straight away. So if someone presents to us with a shock state or if they have hyponatremia and if especially with concomitant hyperkalemia, this should be a differential diagnosis we need to think about, and we need to start treating with IV hydrocortisone and IV fluids straight away rather than waiting for 36 hours or 24 hours like what happened in this lady. And we should not wait for the investigation. So that's one of the things what I would like the juniors to realize. So if you suspect adrenal insufficiency, take a sample for cortisol if possible. Even if you can't get it, leave it, give IV hydrocortisone because that's what is going to save the patients, and start on fluids we can always evaluate that later. Don't wait for a cortisol levels to come back. I think that's one of the important things. And once we correct the give hydrocortisone, that should do the trick most of the times.
Yeah, thank you, Mani sir. And Aruna madam, your inputs about Addison's disease.
Definitely. Being Addison's the biggest issue, the patient presenting with primary hypothyroidism, I would look into autoimmune etiology. So usually I always check if patient has a TSH over, it's the initial presentation over 100 before I start her on hypothyroidism. I mean, levothyroxine replacement, always check the cortisol to make sure you rule out adrenal insufficiency.
Yes.
So that's very important. And I wonder whether this patient did have that and nobody really picked up, and she was given, levothyroxine replacement, because that's not the standard of practice I see here. And number two, she could also have developed later polyglandular autoimmune syndrome. So primary hypothyroidism and Addison's goes towards autoimmune diagnosis very strong.
So this lady has had hypothyroidism for a long time, madam. So this is an acute presentation. So I think she's developing later. So I agree with your point. So I think we need to rule out adrenal insufficiency in patients with profound hypothyroidism. Agree.
Absolutely, sir. I had a patient who was treated with hypothyroidism, and her problems were aggravated with thyroid replacement without treating adrenal insufficiency in that patient. Then we noticed that it was the primary problem was Addison's. Then after that, she improved well. So thank you. So, sir, you unmute, sir. Kumar, sir, please unmute.
Just one comment. Yes, regarding the autoimmune polyglandular, it's always better to always check for, as Dr. Aruna mentioned, the thyroid, as well as any diabetes, as well as PTH levels as well. Though type 2 APS is more common than type 1. We can look at the mouth when you look for pigmentation, any mucocutaneous candidiasis kind of features in favor of type 1. So yeah, obviously, I'm sure you would have looked all that just for public. And very important point Dr. Aruna mentioned, I too wanted to say, is that make sure you start steroid first and thyroxine next. There's no rush for thyroxine, even if it is myxedema, coma. You give hydrocortisone first and then go for thyroxine replacement. Would be a point to say.
Yeah, thank you, Kumar sir, and thank you, Aruna madam. And next we go to case 3. This is a case of hypokalemia with hypertension. A 33-year-old Caucasian female presented with endocrine clinic with intractable hypokalemia in spite of oral correction and uncontrolled hypertension. Her blood pressure at presentation was 161/89 and potassium was 2.7. She was mostly asymptomatic, though she did report intermittent shortness of breath at night, occasional abdominal pain, muscle cramps on exertion, denied nausea, vomiting, chest pain, diaphoresis, headache, visual disturbances or giddiness. Then she denied smoking, alcohol, drug illicit abuse. Then significant hypertension since early 20s, and family history of significant hypertension and type 2 diabetes on maternal side. Denied a stroke and medications on amlodipine 10 mg OD, lisinopril 20 mg BD, carvedilol 6.25 BD, and there were no allergies to medication, and physical examination was within the normal without papillary edema. Madam Aruna, madam, can you go with the differential diagnosis for this case?
Definitely. So basically, here we are looking into hypokalemia and hypertension presentation. So most commonest is, we all know, is hyperaldosteronism, and that could be either from adenomas or idiopathic hyperaldosteronism. It could be bilateral or unilateral. And the less common ones are unilateral hyperplasia or familial hyperaldosteronism, or pure aldosterone producing carcinomas, or ectopics, like aldosterone securing tumors that you find that in ovaries or kidneys. So, but then we also need to make sure we rule out secondary causes of hyperaldosteronism, like diuretic therapy or Cushing syndrome, ectopic ACTH, secretion syndrome, renin secreting tumors, or Little syndrome. And the other ones are the non-aldosterone mineralocorticoid excess. Also, you need to really look into it, like chronic licorice. So these are a couple of the few things that anytime when we think of hypokalemia and hypertension, we need to really look into. But the most common that we think is primary hyperaldosteronism.
Absolutely, madam. Then the investigation showed a normal complete blood count, a normal basic metabolic profile with the exception of potassium of 2.7. Serum aldosterone level was 89.7. Normal range was up to 60 nanogram per DL. Plasma renin activity was PRA was 0.26. And aldosterone renin ratio was 345 nanogram per DL per nanogram per ml per hour. Normal range was up to 30. And pheochromocytoma and Cushing workup were negative. And electrocardiogram was normal. And imaging cardiac echo, normal left ventricular function with EF of around 58%. An abdominal CT revealed a well-defined left adrenal gland lesion with an absolute washout time of 80%, 85%, and relative washout time of 50%. And lesion was 11 into 17 into 13 mm in largest diameter. So, madam, can you explain me about the investigations part in this patient?
Definitely, this patient meets the criteria. So criteria is spontaneous hypokalemia. This patient was not on diuretics. And apparently the patient was previously admitted with the potassium of 1.9 and with the U waves, and she was treated and was sent home on potassium replacement and then referred to us for further evaluation. And progressively, she needed additional add-ons of her antihypertensive agents. You can see she was diagnosed very young, but then always poorly controlled. So she meets the three criteria: spontaneous hypokalemia, and elevated plasma aldosterone concentration greater than 10, and a very low or undetectable PRA levels. And her PRA and PAC-PRA ratio is greater than 20. So biochemically, we have now at least evidence that she has primary hyperaldosteronism. Of course, we have ruled out the other causes. Could it be PHO? Could it be Cushing's? Those are also ruled out. Then primary hyperaldosteronism patients are very high risk for cardiovascular events. Definitely, we need to make sure that underlying cardiac function is good, and they are very high risk for cardiac failures. So we did the echo. And the abdominal CT, of course, it's a very important one, with and without contrast. Hypodense washed up lesion was noted on the left side. So we do have now an aldosterone producing adenoma here.
Thank you. So coming to the confirmation test, primary hyperaldosteronism, we have captopril suppression test. Before treatment of captopril, PRA was 0.01 and PAC was 80.1. After treatment of captopril, PRA was 0.01 and PAC was 72.3. Only 6.2% decrease in PS after captopril, and a selective AVS was done, and selective simultaneous non-stimulated adrenal sampling was performed at lateralized lesion to the left adrenal. Aldosterone level in the left AV was 30,346 nanomoles per liter. Compared to right, it was 3,000 nanomoles per liter. And the aldosterone to cortisol ratio of the left AV was significantly higher than the right one, and it measured 9.8:1, and diagnostic cutoff was more than 4.1. So, madam, coming to the discussion part, can you tell me about the electrolyte management in this patient and about the management of this primary hyperaldosteronism?
Definitely. So the electrolyte part of this patient, since she was very hypokalemic, of course, the suppression test, we couldn't suppress her, and the lateralization lateralized to the left. And so we know it was APA. So as per guidelines, whether the patient needs to go for surgery or not, less than 35 surgery is highly indicated. And so greater than 35, if they are not willing for surgery, we can consider medical management. So because the treatment consists of three goals: reversal of cardiovascular risk or disorders, and normalization of potassium and normalization of blood pressure. So we have to block. So once the tumor was removed, patient improved considerably, and in fact, she dropped down to one medications, in fact. So, and she does have family history of hypertension, so we know that's probably essential hypertension thereon, or also post-surgery, her immediate post-op PAC level dropped to less than 5, showing that was a very perfect surgery and the entire tumor was removed. So with her, it was easy, it's straightforward, but usually it's not so, we all know. So a lot of times it's the bilateral idiopathic hyperplasia is the most common. I mean, idiopathic hyperaldosteronism is the most common presentation, greater than 70% compared to adenomas, which is 30 to 40%. So medical management is the thing. And a lot of times, even if the adenomas are there, we are not able to really localize them. So even AVS, unfortunately, what you need, it's a great test, but unfortunately you need a very, very, very trained or centers that are very good in doing it with very high experience. A lot of time canalization is not really good. So we have medical management. We go for the mineralocorticoid antagonists, spironolactone and the eplerenone, which is the latest one. Of course, spironolactone, we know it's there for 50 some years. And with the both unfortunate endocrine side effects in men and women, other than that, it's really tried and tested. We usually start at 12, 12.5, and we can go up to 25 milligrams. It can be given once a day. But on the other hand, the eplerenone with this very less, but then we can go do it up to twice a day, which has no other endocrine side effects. But we still don't know the long-term outcome of this, but it's equally a good one. If both are not tolerated, you can go for amiloride, the other potassium-sparing medications to help with the management.
Yeah, thank you, madam. And we know the Endocrine Society guidelines for screening of primary hyperaldosteronism. And we have to screen for every patient whose blood pressure is more than 150/100. And then with hypertension, with resistant to 3 conventional antihypertensive drugs, with hypertension and spontaneous diuretic induced hypokalemia, with hypertension and adrenal insulinoma, with hypertension and sleep apnea, with hypertension and a family history of early onset hypertension or cerebrovascular accident less than 40 years, and all hypertensive first degree relatives with patients with primary aldosteronism. Thank you, madam. And we'll go for inputs from Kumar sir, please.
Just one comment here is very recently they have, thanks for a very nice presentation, and Dr. Aruna, that was very clear. Recently the many essential hypertensions, so-called essential hypertensions, they have found out they are having hyperaldosteronism, whether it is idiopathic or adenoma, but it is if the blood pressure is slightly resistant to treatment, not necessarily 3 drugs, we have to think about hyperaldosteronism as one of the reasons. So we have to be thinking about it. And another thing is, yeah, this lady being a young lady, it's fine. There is a clear-cut adenoma. Went for the operation. Sometimes centers may not be able to do the adrenal venous sampling, and they go for adrenalectomy. But especially more than 40 years old, we all know that many patients have adenoma-like features on one gland. They may be hypersecreting from the opposite gland. Sometimes it can be a bilateral disease. So adrenal venous sampling becomes important. I mean, spironolactone, eplerenone, all these things. I mean, she can be cautioned about this pregnancy chances and the potential teratogenic effects of the medications if she is on it. In a few comments. Thank you.
Sure.
Yeah.
Thank you, Dr. Kumar.
Thank you. Thank you, sir. We are only left with 10 minutes, madam, and we'll go for summary, and then we'll go for question and answers. Okay, madam?
Sure, sir.
Yes, please. Yeah.
Yeah. Sorry. So I want to summarize the endocrine causes of hypokalemia, like increased availability of insulin will cause hypokalemia and hypolikalemic periodic paralysis. in thyrotoxicosis or increased urinary losses like increased mineralocorticoid activity like primary hyperaldo or AMA, apparent mineralocorticoid activity or renal tubular acidosis. Then we have endocrine causes of hypokalemia like metabolic acidosis, insulin deficiency, hyperglycemia, and hyperosmolality, and reduced urinary potassium excretion, reduced aldosterone secretion, or reduced response to aldosterone, that is, aldosterone resistance may cause hypokalemia. Coming to hyponatremia, as discussed earlier, disorders with impaired urinary dilution due to unsuppressed ADH secretion because of reduced effective arterial blood volume as in Addison's or SIADH, that is euvolemic hyponatremia, like hormone deficiency or hormone administration also can cause this. Then coming to very rare cause of hypernatremia, central or nephrogenic diabetes insipidus, osmotic diuresis, glucose in uncontrolled diabetes mellitus, hypothalamic lesions impairing thirst or osmoreceptor function or primary hypodipsia or reset osmostatin mineralocorticoid excess. These are the common causes of hyponatremia. Uh, I think we have covered all the reasons of endocrine hypertension, starting from hyponatremia, hypokalemia, hyperkalemia, and hypernatremia. Sir, any inputs from Kumar sir and Manikandan and Aruna madam about overall electrolyte disorders in endocrine part? Please go ahead, madam.
This is one of the most important thing that unfortunately a lot of times is missed, especially in patient setting, it's missed. And chronic hyponatremia and chronic hypokalemia is also missed as outpatient. At least hypokalemia is addressed, but hyponatremia most of the time is missed. So I would greatly encourage if you start seeing repeatedly, don't think it's a lab error or just the usual pseudo hyponatremia causes ruled out. Go ahead and really look into it. The reasons, are there endocrine causes or non-endocrine causes for these electrolyte disturbances? Because they do have long-term clinical outcomes. They are not as innocuous as we call it. They do cause cardiovascular, serious, sometimes cardiovascular risk outcomes like primary aldo.
So I think, as Madam said, I think we need to definitely think about investigating these even minor electrolyte abnormalities when seen as an outpatient and inpatient as well, because it can significantly reduce the morbidity associated with it. Because quite often we see someone presenting with severe hyponatremia in a comatose stage or after a fall with subdural hematoma. When we look at the previous reports, they might have had a sodium of 128 or 125, which was missed. And these episodes of readmission could be prevented. So definitely we need to look into this as soon as we see a minor abnormality.
A few points I would like to say is for the clinicians to assess very carefully in a hyponatremic patients and assess daily if needed, even a couple of times a day, to assess the fluid status, which can be changing and the picture can be changing to arrive at the right diagnosis. And please don't rush in to use tolvaptan is the underlining message I would like to convey here.
Yeah, Kumar sir, we have 2 or 3 questions on tolvaptan. They are asking about the abuse of tolvaptan, and can you explain about tolvaptan in a minute, sir?
Certainly, sir. So tolvaptan, as I mentioned earlier, is as others mentioned as well, most abused medicine for treatment of hyponatremia. They just had, it's no, I don't mean anything, but junior people think hyponatremia, so the treatment before the specialist or the consultant comes is to give normal saline and give them tolvaptan. And that idea should be taken out. So first thing, as I said, clinically assess properly, and then only when the SADH diagnosis is confirmed and the fluid restriction are not helping, then we can think about tolvaptan. And after starting tolvaptan, keep monitoring the sodium very carefully and adjust the dose. It can go maximum up to 60 milligrams a day. So adjust the dose daily, assess clinically, assess the sodium, and treat it. And in pneumonia and other reversible causes, the hyponatremia SADH may not be forever. Some people it settles down in 2 to 3 weeks. But most people, when they go home, they need some dose of tolvaptan but make sure to bring them back or at least check their blood report and analyze, clinically see them hypovolemic or euvolemic, and make further decisions. They may not need for a long time, but there are instances who once started on tolvaptan, they go on for many, many months. They don't settle at all, needing a small dosage for a long time. So it all depends individual patient wise, and no standard rule applies. Repeated assessment is the only way forward.
Yeah, thank you, sir. We have so many questions with only 4 minutes left for us. And we have an interesting question. Dr. Sandesh asks, patients of diabetes on SGLT2 inhibitors, what precautions should be taken to avoid electrolyte imbalance? Manikandan, sir.
So I think the main thing is to avoid using loop diuretics along with the SGLT2 inhibitors. Not everyone presents electrolyte imbalance, but if they develop it, then we need to look at the other drugs which might cause it. So, but most of the time, I think, unless they are on loop diuretics, they don't develop electrolyte imbalance with the SGLT2. That's what I have seen. And if at all, if they develop, I think if, without any other drugs, it will be better to stop it if they develop electrolyte imbalance.
Most in my experience, I've used it extensively. Initially, I see it, but then later it seems to reset and in fact correct itself and back to normal. So I'm not seeing really chronic hyponatremia or serious hyponatremia that they ended up in the emergency room, to my experience or knowledge. Dr. Kumar?
Yeah, I agree. In fact, I don't really follow up the sodium in SGLT2 patients whom I start on, which is not that common. I think it may be minor differences to begin with. And primarily, it doesn't excrete the sodium. It just excretes the glucose and a bit of water along with it. So I don't think we need to worry too much about the sodium.
The sodium is lost along with the glucose, I think.
Yeah, not to a
not too much.
great degree. Yes, agreed.
Yeah.
Yes.
So then we go some more questions are there, and then we have so many questions on about the diagnosis of PRA and aldosterone renin ratio, these protocols. So I think these can be answered by Endocrine Society guidelines, and we have a strict protocol for all these tests and where they can be done and what are the precautions to be done before these investigations. And then we have some questions about 3% NaCl, asking about that. We think we already answered, Kumar sir answered about 3% NaCl and what the care should be taken, and we are not supposed to rush so that we are damaging the patient about causing the pontine demyelinosis. And questions about steroids. What is the best steroid available to our patients in adrenal crisis, sir? Kumar sir.
Yesterday, I just want to mention one point. Yesterday, we had a very interesting talk about this steroid replacement by Professor Karim Miran from UK, and his objective is to switch from hydrocortisone treatment to prednisolone. One is the contention is treating somebody with hydrocortisone for adrenal insufficiency. We are giving most commonly too much steroid than needed, and multiple peaks do not help in long-term cardiovascular outcomes. So he proposed prednisolone, which has less mineralocorticoid activity than the hydrocortisone and gives a stable level of steroid level. And Addison's probably we should all. I mean, in India, of course, lots of people are on prednisolone, but they are all slightly on a higher dose, like 10 milligram. Most commonly, I see in prescriptions. What he advises is a 3.75 milligram of prednisolone is more than enough, but we have only 5 milligram tablets, and he suggested to break it into 3 and 3/4 of the medicine to be given to be ideal and follow clinically. Prednisolone levels we can't get that easily, so clinically and electrolyte symptom wise and electrolyte wise we can follow up those patients. So there's a study going on in that area.
I think for adrenal crisis, hydrocortisone is the only drug which I think all of us would recommend. I think it's for chronic thing, it's debatable, it's changing now.
Yes.
Yeah. So thank you so much all the panelists for a enlightened discussion today. And this 1 hour we had a nice discussion about electrolyte imbalances and all the endocrine disorders. Thank you, Dr. Kumar sir, Dr. Manikandan, and Dr. Aruna. I think we are on a short time and we are giving back to Dr. Deepika. Thank you so much, Trendo, for this opportunity for us. It's indeed a pleasure and honor to be with you all people. Thank you so much.
Thank you, one and all.
Thank you so much.
Great presentation, and thank you, Dr. Ramanathan, for
Thank you.
excellent moderating. Thank you.
Thank you.
Thank you so
Thanks a
much.
lot.